So this was a young gentleman who showed up and had a murmur on exam for a sports physical where they were trying to play college athletics. So typically the easiest is when we're scrolling through is we can just start by following our blood flow. So I'm looking at my SVC here. It's coming down to an atrium. I'm following down. I see the IVC. It looks kind of dilated. We've got a dilated coronary sinus also coming back to this atrium. And it's going to a ventricle here, but that doesn't quite look like a normal right ventricle, just off looking quickly here. It's going, following here to, it looks like a pulmonary artery. Then we're looking at what comes back in terms of our pulmonary veins. And so I always kind of just follow. So I typically do for pulmonary veins, I start from my right upper, following here. It's coming back to the heart. I've got a right lower pulmonary vein coming back. I've got a left lower pulmonary vein, a left upper pulmonary vein. So that all looks like it's connecting normally. We've got a big atrial appendage here coming back to a ventricle. Looking at this ventricle coming down. And then that is going to our aorta, which is giving rise to our coronary arteries. And then our aorta, it's a left aortic arch. And our head and neck vessels are kind of cut off, but they're coming off normally. So does anyone have an idea of what this is? Again, this is an example of an L transposition. And then the other thing here is looking, he doesn't have any VSDs. He had a bunch of tricuspid valve regurgitation, and so that's what the murmur was coming from. And so he had systemic tricuspid valve regurgitation. But again, this is a favorite question on all imaging boards of really being able to recognize L transposition. And the key here also is that you've got this really small left ventricle that is kind of hypoplastic, and it'll be very D-shaped, which is because this is our systemic ventricle. But this is an example of an L transposition, and this is the most common of what will show up in adulthood. So this is what you'll see in terms of the most complex of congenital heart disease that's undiagnosed. Any questions here? What will be diagnosed, but often comes in and is our complex single ventricle heart disease. And so when we think about complex single ventricle heart disease, and I apologize, I was going to go earlier this morning and I was actually at the hospital dealing with this exact issue, is our single ventricle patients will come in with chest pain, and they will often have a lot of issues in terms of being short of breath, and they'll have heart failure, and they show up to the ER and nobody reaches out and they get CT scans. So what's important to understand for single ventricle heart disease is there's lots of different flavors of ventricle heart disease, but once you've gotten to a Fontan, the general concept, and there's flavors of Fontan, but the concept is always the same. So again, if we start and we just follow our blood flow, you can see here again, we're following our SVC, and this is actually a surgically created Glen is what it's called. But the SVC has been surgically connected directly to our pulmonary arteries. So we look here and we see our pulmonary arteries coming down. Blood then comes back to a common atrium, most commonly, and they've had actually a surgically created non-restrictive atrial septal defect. So we have a single common atrium because we have a single ventricle going to our common ventricle, and then a single ventricle going out to our aorta. And then if we come down here and we look at our IVC, that's connecting here through our fontan. And this is an example of a lateral tunnel fontan coming directly to our pulmonary arteries. So the challenge with this type of an anatomy for these patients is when they get their CTPE studies, you get mixing artifact, and this isn't actually the worst of mixing artifact, but you get mixing artifact in the pulmonary arteries, and these patients do get pulmonary emboli, but what they get more commonly is misdiagnosed pulmonary emboli. That's mixing artifact because you have essentially non-contrasted blood coming in from your IVC directly to your pulmonary arteries. And then you have contrast that's going directly to your pulmonary arteries, to the PAs, and you get mixing artifact and they get PEs read all the time. So for these patients, they really have to have delayed scans to have diagnostic PE studies. And then the other thing that's notable is any adult fontan, if you see all these extra tiny little blood vessels, they get these collateral vessels. So almost all these patients are to some degree cyanotic. And so they can walk in and a lot of them have O2 sats that are in the mid 80s. And they're walking around and they're totally fine with O2 sats in the mid 80s because they have all these collateral vessels that develop, which typically go to the pulmonary veins. And so you have an extra cardiac shunt from these vessels that you're seeing.